Hello, welcome everyone to the Patient Partnership webinar series. Welcome to this special webinar on the patient experience and how ERNs hospitals partner with patients. So while everyone is joining the webinar, I will use these first minutes to explain you and to give you an overview about the webinar. Just 1 second, because it's not going to the next slide. Okay. Okay. So I will give you first an introduction and an overview about the webinar. So first of all, some recommendations for today's webinar. So please mute your microphones when you are not speaking. Turn on your camera, especially during the Q&A time. And it's nice always to see your faces. And also add your name in the participants list. So change your name so we can see who you are. And raise your hand if you wish to speak. But don't hesitate also to use the chat box for any comments and also for the Q&A. That there will be some time for questions and answers at the end of the webinar. For your information, this webinar will be recorded. And at the end of the webinar, we will send you a satisfaction survey that you can already access through the Q&A. So we'll really like to hear from you and to have your feedback on the webinar and to see if you like it and how we can improve them. So I will give you an overview about the agenda for today's meeting. So today's meeting is part of the Jordi's Patient Partnership webinar series. Usually we organize these webinars once a month, and we use this opportunity to showcase collaboration among patients and healthcare professionals in the ERNs. Today's session is a little bit different because we would like to highlight and to show you how patient partnership can also be organized to improve the healthcare services in the hospitals that host ERN Expert Centres. For this, we'll have 2 speakers from Sant Joan de Déu Children's Hospital from Barcelona. We'll have Joan Vinyets Rejón, who is the head of the patient experience area, and also together with Jordi Antón, who is the head of the Paediatric Rheumatology Department and also member of ERN Rita and ERN Rejón. So for this webinar, they will explain us the patient experience program and how is this program contributing to improve healthcare services in the hospital and what's the role of the patients in this program. So first of all, they will provide an overview about how they organize the patient experience program, and also they will show us the guiding principles and the collaborative approach that they are using to carry out this program. Then they will provide more concrete examples about how this is organized, and also concrete examples on the impact that these practices can have also in the work of the ERNs and how the ERNs are also using this. And then they will explain us, and they will, the collaborative approach, which we also call enablers. And they will explain also why is this patient partnership good practices. We understand for patient partnership, the collaboration between the patients and the health professionals, and in this case also with the hospital managers, to improve the healthcare services. So now I will give the floor to Joan and to Jordi, so they will be able to explain us the patient experience program. So I will stop sharing, and they will start sharing their presentation with more details for the webinar.
So, thank you so much. Can you hear Me? Okay,
Yes.
perfect. Well, first of all, we want to thank you for the invitation. It's a pleasure to be here today with Dr. Jordi Antón. And the idea is to try to share with you some insights and learnings from this collaboration. And yeah, just, as a starting, it's to provide you some kind of background. So first of all, to say that this patient experience area or unit was created more than 7 years ago in 2015, and with the idea to provide this value to the healthcare professionals in order to improve the patient experience, satisfaction, and quality of care through a human-centered design approach. That is the approach that we provide, and about facilitating the continuous improvement and innovation of our care model, and of course co-designing with people, with users, patients, families, and professionals. The idea, one other key goal that we have is to facilitate this more humanized and people-centered healthcare model. And to do that, we try to enhance the patient centers and facilitate the involvement of patients. Till now, in these years that we've been working and collaborating in several projects, basically, I would say that the key actions and milestones that we achieve, it's, first of all, it's to explore and understand the current state of patient experience. Then also the fact of engaging patients and family and professionals and key stakeholders in the experience design. Of course, also been developing some pilots and validating patient experience improvements, strategies and actions. And also a key milestone, it been, to make the patient experience program a key discussion topic in healthcare professionals and management teams meetings. In several meetings that we are carrying on every year here at the hospital, patient experience now it's a topic on the agenda of these different meetings. So then, turning to the new slide. Sorry, I think I have a problem with the. Let me check.
It is sometimes taking some time, but at the end it's possible because I had an issue.
Yeah, sorry about that. So basically, about this background information at the end, as a team, patient experience is a collaborative team. We work together with process. It's a team that they work to analyze all the processes in terms of applying lean methodologies. Then also we collaborate with voice of customer team. This team is in charge of getting feedback from patients and families. So at the end, we are more than 12 professionals with different profiles, from biomedicine, nursing, anthropology, sociology, public health, design, engineering, and economy. So here it's interesting because the idea is that, of course, we provide the complementary expertise to the expertise and knowledge that the professional healthcare have. So that's the idea of this blend of backgrounds and profiles. Then in terms of our methodology, I would say that it's a kind of a multi-method approach, and we use a diverse spectrum of methods for understanding patient needs and pain points, and to enhance the entire patient journey. So on that, we put together tools and methods from different domains. We use techniques and activities to generate, to develop generative research workshops. Sometimes we use tools coming from the creative problem-solving domain for developing co-creation sessions. And in other cases, we use some tools more qualitative, coming from ethnography or qualitative research, as for example, experience diaries or in-depth interview. So here on the bottom, you can see some images in which you can see some of the tools that we use to approach patients and professionals and to engage them. From one side, to gather insights, and from the other side, to provide the stimulus to facilitate the generation of ideas when we think about ways to improve our integrative model of care. So it's a multi-method approach with these very different techniques and methods. Then, when we were planning this webinar, our audience were asking, how patients engage. Engagement has contributed to enhance these hospital services. Here, I wanted to share some facts about last year with our focus on understanding the value of people expertise to achieve this continuum improvement, innovation, and co-design. Always it's based on understanding their needs and with involving them collaborating very actively. So here you can see a sum up of some facts about last year. Last year, we developed more than 250 in-depth interviews with patients and families, more than 80 in-context observations in different sessions around the hospital, around 50 focus groups, in which also participated families, patients, and professionals. We developed more than 70 daily activities logbooks, and we developed 16 co-design sessions, and also more than 20 user tests to validate some of the concepts and ideas that we developed with patients and families. So here also, you can see several pictures. As you can see, one of the pictures is from one of the sessions that we just did last summer. You can see here, in this summer environment. Also, we did, for example, you can see sessions in which we were doing role playing. You can see one dad and her daughter that they were role playing a little bit. So this also was a good way for us to understand what are the things that they worried them, what are the needs or pain points. So as you can see on the images, several methods to gather insights and to facilitate this engagement with patient families and professionals. Then it's interesting because when we're looking at preparing this presentation also, I think it's very similar in terms of the ERNs principles that you have at EURORDIS. So in our case, patient experience principles in our hospital, the first one, it's a process that it's human-centered. So the idea is that we focus on people, patient, families, and professionals. Then also it's the idea that it's along this journey, working, collaborating with patients, families, and professionals. Always we try to keep this kind of co-creative mindset. So the idea that it's that we need to emphasize always with all the different persons, and we have to keep this creative and participative, collaborative mindset along the journey and with the different interactions with them. And finally, always the idea that it's a kind of agile development, which, it means we always put agility, dynamism, and trying to have different interactions for continuous improvement. And the idea, it's to prove all things in a very basic prototypes with different interactions, learning by doing and learning also by failing. So that's kind of the idea. So you can see that it's very similar at the principles that also you are using at all the ERNs activities. So then, jumping a little bit about the patient experience framework, this is a visual about, our process, how we organize our projects and our way of working. And in here also, again, I think it's pretty similar at the way in which you approach at EURORDIS, the projects, with this idea of consult, involve, co-create, and share. And this is our ideas that you can see here in this visual of the process. So the idea is that first, before to start, we plan. Then based on this planning, then we start the understanding phase, in which it's full immersion, fieldwork, and try to understand from the point of view of the key users, patients, family, and professionals. Based on this understanding, then we use all the insights to generate ideas, and then we prototype these ideas. And then in the third phase is when we do pilots and we do follow-ups and evaluate. And finally, at the end, on the last phase is when we communicate and share all the learnings and insights from the process. What's important to retain here in this visual, I think it's this idea of diverge and converge, this idea that it looks like diamonds, no? We diverge and converge, the idea that sometimes you have to open a lot at the beginning when you are doing the immersion for the understanding, but then you have to converge when you are generating ideas or when you want to develop some of the prototypes. And here again, you can see on the right side some pictures of some of the dynamics and prototypic sessions and ideation sessions that we've been doing with patients, families, and caregivers and professionals. So this is a little bit our approach. Then basically we work, to develop and co-create care models, to co-create the spaces at the hospital, also to improve the professionals' experience. Of course, we do also research, and in fact, Dr. Jordi Antón, he will share one collaboration in which we've been developing a research and applying our methods with their approach. And of course, also, we are working a lot on trying to explore and co-design digital channels and new resources to interact and to contact with patients and families. So basically, this is the work that we do. And just to share you a couple of 3 projects, and then I will pass to Dr. Jordi Antón. But basically here, for example, a sample of projects that we've been working. One, it was a project that we developed. It was called Common Needs. And here, the idea was to identify common empowerment needs in complex chronic patients with rare disease. So this was done during as you can see, during the pandemic. So this is why you see a lot of virtual sessions on the pictures. But based on that, nowadays, we are developing some information materials and resources for provide, solutions at the needs that we identify during this project. The other project that you can see at the center of your screen, it's called Seguim. It's kind of, okay, let's continue. And this is a project that we developed last year, and it was how we could redesign the oncology patient care and follow-up unit at the Paediatric Cancer Center Barcelona. And here you can see on the pictures, we involve patients, families, and professionals. And it was really interesting and inspiring because, for example, this unit, it was called the Survivor Unit. And one of the biggest insights, I will say, we got from the involvement of patients, it was that please change the name. If you call at this unit survivors, you're still seeing me as a disease, not as a person. So it was really meaningful. And in fact, nowadays, the unit is called Seguim. So let's continue together. And I think that, it shows one of the big values that involving patients and families provides to, to a hospital or like us. So, and finally, the last one, it's Aprendemos. It's kind of let's learn together. And this is a project that we're still working. It's a training itinerary designed to train caregivers and patients with hemophilia and other congenital coagulopathies. So in this one, we did the field work, we did the identification of the insights, and nowadays, based on the needs, on the pain points of these patients and families, now we are developing all the training program that we will provide through a digital platform. So, I think it was interesting to share you some short samples about the type of work that we do. And now we will go in deep to another project. So over to you, Jordi.
Yes, thank you very much. It's a pleasure to be here today with all of you, and I will try to summarize briefly our experience with our colleagues from the patient experience with a project which is called PAVE, Production and Arthritis Value Framework with Economic Evidence, Paving the Way for Rare Childhood Diseases. It's an European joint program on rare diseases. It's a grant we got with several countries. And we worked in 6 different work packages from colleagues from Canada, Germany, Switzerland, Spain, Israel, and Belgium. And each of us were in charge of an aspect, trying to work on unmet needs. And our work package was focused in identifying the unmet needs of uveitis associated to juvenile idiopathic arthritis. Juvenile idiopathic arthritis is the most common pediatric rheumatic disease because, yes, kids have also rheumatic diseases. And 20% of these patients can present uveitis and inflammation of the anterior chamber of the eye. And this is important because this inflammation of the eye is without symptoms, but can have severe involvement and can have loss of acuity, visual acuity, and severe impairment of vision. So we realized that this was an unmet need, and we wanted to use this program to check about that. And we have done it through a great, wonderful collaboration with our colleagues from patient experience. And thank you to their help. No? Our work package has 3 phases. The first one, as Joan has introduced you, for a qualitative study, a second one for a quantitative study, and a third with thinking about design and co-creation. And for doing that, we have used different research techniques, to learn about the patients, their families also, because we are working with kids. And we had several observation sessions in where colleagues from the patient experience come to our pediatric rheumatology visits. They also were attending pediatric ophthalmology visits. They also attend sessions with the rehabilitation the team, the physiotherapist, the physiatrist, or, for example, intraarticular joint injection sections. And then we had several in-depth interviews where they ask about the journey of these patients, their needs and worries, and the expectations about their future. And they analyze patients with juvenile idiopathic arthritis and uveitis, and those patients that have juvenile idiopathic arthritis and without uveitis. They also developed some daily activities logbooks in order to understand the illness, the needs of worries of these kids and their parents, and the daily life at the school, holidays, going to doctors, appointments. And they developed wonderful digital logbooks. And then we have focus group with patients and families where were defined the analysis of the information obtained by the previous techniques. There were 4 sessions with 5 participants each one, and there were also subgroups according to different ages, which is something that we always must pay attention to. This on the right side, you can see some of the experience diaries. I mean, they are very creative, I must say, and they develop challenges, for example, the Sherlock Holmes Day or the journey through the galaxy, and instead of Star Wars, they talk about Star Age, or I like Wednesday, or the Godbusters in Action, or a trip with Moana, or the interview of a superhero. So in order to engage patients in all of these activities and to make them happy to collaborate and share their experience, deciphering GA enigmas, or how they define their working routine during the life, or how was their experience at the diagnosis of the disease, or when they were diagnosed with the uveitis. So in order to collect as much as possible information, but as we have here in the hospital, with a view not focusing only in the disease, but only in the daily life of patients and making them the experience as good as possible for them. So This European grant has a duration of 3 years, covering the 3 phases. In this first phase, we have had the qualitative study with the interviews to professionals, with patients associations also who are involved, which are involved, and uveitis association, JAA associations. Also, these interviews with patients and families. And then we have this second phase of the study where we will survey to different groups of patients and families that are in the phase 1, patients with JAA without uveitis, JAA with uveitis, and health controls also, and another group of patients with a chronic disease. We have chosen diabetes because it's quite similar incidence and prevalence that JAA, but without the involvement of joints and uveitis, in order to identify which are the differences between one disease and the others. And then it will come the third phase, the design of co-creation, with a method that personalized design and co-design sessions with patients and families, and so we can provide strategies and action plans to improve our care of these kids. And yes, a brief overview, like spoiling, which are the data and information we get from the qualitative research, and which are the opportunities, after the analysis of the qualitative research, which are the areas of opportunities we identify. One is the management of remission of flares. One of the main concerns is the instability caused by the flares of both pathologies, JAA and uveitis, that requires constant change and adaptation to change that impacts in quality of life. So it's important to accompany patients and families in managing this remission of flares. Then, it's crucial, and I believe that sometimes we don't pay attention as physicians, although we know that, but in our daily life, try to forget, and I try to always remind, it's learn to live with uncertainty. I mean, it's crucial, and it's one of the areas of opportunity we have identified. In this disease where uveitis is only recognized through a visit to the doctor, but it could be very severe. It's not that they have pain, it's that they have, till they don't have a severe loss of vision, it can be a flare and they don't pay attention. To life with uncertainty, it's important, And also the invisibility of uveitis, how it forces to live, and sometimes how they face the lack of understanding from their colleagues, or also from other physicians who are not aware of these pathologies, Also, to resolve the misunderstanding, because, I mean, as I said at the beginning, kids also get rheumatic disease. Everybody knows about rheumatic diseases in adults. Everybody knows about diabetes in childhood, and arthritis has the same incidence and prevalence that diabetes, but a lot of people doesn't know that there are kids with rheumatic diseases, So it's difficult to explain these diseases, and families and patients in more support in front of the healthcare system, also in the schools and society, And also the last one is to reduce the self-demand and guilt, which is also common with other diseases, but it's important to recognize how sometimes there is some degree of pain that they don't pay attention, don't know how to sterilize, and they normalize a situation that impacts on their quality of life. So this is just the spoiling of some points that we will work in this quantitative, some of the points we will work in this quantitative phase, and then to create a better care for these patients. And I must say, I mean, it's incredible to work with the team of Joan and to have this group of focus to the patient experience, because really helps us to work with them and focus more in patients' needs and what patients need. And moreover, it also, it was discussed yesterday in another webinar, to have data, real data that we also can share about which are the unmet needs, not just what you think or what you believe or you have heard. No, these are real data that we can use later to improve. Yeah. And then, I mean, this is the value of to co-create, no? To co-create for better healthcare services, to facilitate continuous improvement, no? Based on patient feedback, enhancing the quality of care and building a stronger relationship with patients and families, and to incorporate patient life experience insights provides healthcare professionals with real-world knowledge that complements medical expertise and deliver more personalized care. And here in the right, you can see, I mean, we have our Day of Rheumatic Disease, the World Day on March. And in fact, we have this work, where structure during 3 years for unmet needs, in-depth analysis about for children with uveitis GAA. We ask our colleagues, hey, we have this session with families, could you help us? And they help us also to work on that day with families and patients to try to identify other points and confirm some of what we have done. And it was really, really an amazing day this March. And that's all from my side. I will be open to questions later.
Yeah, thank you, Jordi. Well, I have to say that the same from us. It's really amazing to work and very easy to work with Jordi and his team. But okay, going to the end of this presentation, in terms of enablers, we were asked, okay, what are the enablers? Well, if we think in these 3 big areas, now, if we think about the first one, culture and governance, well, one of the things I think is very important is that management leadership commitment to the patient experience. So it's very important that through the whole organization, it's actively supported, this idea of patient experience. That's basic. Otherwise, nothing will happen. Then also, patient experience should be embedded in the organizational strategic objectives. So when we talk about quality, safety, processes, accreditations, always also we have to incorporate patient experience. Then, of course, always incorporating the patient voice into strategic discussions and ensuring that it's reflected in the organization mission and vision and across all the dashboards for the organization. This is very important. And for example, here, families and patients are involved in the strategic meetings with the general managers once, several times per year. So then another point is active and demonstrative communication, which it means that, it's important to promote the importance of patient experience, communicating at all levels of the organizations, then also disseminating and reinforcing this idea of patient-centered values and procedures to all the people and teams. And of course, then also in terms of visibility, it's important promoting a strategy of feedback and recognitions for patients, families, and professionals that have collaborated in the improvement of patient experience, and also giving explicit value to the time that they have dedicated to them. Because, for example, in terms of the healthcare professionals, this is always extra work. So then you have to provide, this, giving some visibility and also to thank for all this work that always is extra to their daily work. Then, in terms of process and organizational arrangements, I think it's important to have a network of internal role models. So it means that to facilitate that, you need to establish small working groups in all services areas and a network of role models that they could act as ambassadors of patient experience. For example, you see Jordi is an amazing ambassador of patient experience. So that's very important. Then also facilitating small ways to reinforce the importance of patients' role. And so it means that you have to offer staff development and opportunities and guidance for applying this. Second point is a structure for patient involvement and empowerment. You need to ensure the active involvement of patients and families and caregivers to this continuous improvement. And then you have to promote opportunities to develop collaborating working relationship with patients. So just before Jordi was mentioning, when we had this day in which, we work with the associations. Also, we have the councils for families and patients. So that's the idea. You have to structure some, resources for making this possible. Then, of course, also you have to, it's important setting a measurement and feedback system and you have to structure appropriate tools, surveys, comments, patient feedback reports, dashboards, and you can use several tools and indicators. For example, we use a lot the Net Promoter Score, but also more qualitative resource. And then, of course, you need to share feedback from patient satisfaction and NPS to all the different services and departments, because that's a good way, a good insight for improvement in all the services. Then finally, in terms of enablers, of course, competencies, skills, and knowledge it's vital, it's very relevant. So it means that you need to provide training and support for the teams. So this means to develop special training programs in different skills, of course, empathy skills, and new agile and creative methods, design thinking, lean, co-creation, etc. But then, of course, it's not only about providing these skills and knowledge. It's also to facilitating and guiding teams with examples, tools, and mentoring to integrate these kind of approaches to the practical applications. And then finally, also you have to encourage conducting small improvements, projects, and test new ideas with the teams. So this is very, very important as well. And finally, before the turn for questions and discussion, in terms of a sum up, I think, if I think about the value that the patient experience could provide based on our experience, it's, that in our case, it's facilitating this kind of active participation of ERN members in patient experience projects. It provides a complementary. I think that's important. It's a complementary, empathic and creative approach to focus on rare disease research process, going beyond the biomedical aspects, because of course, all the biomedical research and knowledge and expertise is very important. But in our case, it's a kind of a complementary approach. Then I think patient experience is a way to foster a permanent collaboration with patient families and healthcare professionals. Also, I think that, it helps to deliver compelling storytelling for sharing of learnings and results in clinical sessions and conference with patients and families. As Jordi mentioned it before, it's not about I guess or I think. It's about, look, this is what reported, this is what they said, these are, pain points that they share with us, these are the testimonials, and these are the quotes. So it's bringing the voice of patients and families in first person to the table. And I think at the end, it brings to the table new generative methods for participation in patient association conferences, to co-create together and help to understand patients in new ways. And because at the end, what we do is, we facilitate sharing this patient lived experience insights. And I think that's the most important. So here, thank you for that. And I think now we can open for questions and conversation.
Thank you, Joan and Jordi. I think that was very interesting. And I see that there are many questions already in the chat. So I will start. Some of them are related, so we'll try to answer as much as possible, taking into account the time. So the first one is from Ines Hernando about the questionnaires. If you have questionnaires to measure patient experience with care in the hospitals, and if you have observed any change in results since you have
Maybe I can explain, Andrea, it's easier. Joan, so my question is whether you have a survey to assess patient experience in the hospital in general, with all the services, etc., whether you use that kind of questionnaire. And if you do, whether you've seen any changes in the results since you've implemented this initiative. So first, the question is whether you have or not a questionnaire in the hospital to measure patient experience more generally.
Well, we have several methods. This is a big discussion always, no? Because first we have the Net Promoter Score, the NPS, that it's been used for so many years on the private sector, and now it's it's been applied in the health care sector, and it's this NPS. It's a metric that is a standard, and it shows you the level of satisfaction. But this is a kind of a general indicator. So it means that the families and patients, they are happy with the care that was delivered. So this is the first indicator. Then now, based on that, what we are also doing is we are analyzing all the comments and feedbacks that the patients provide, because always that there is a visit or an intervention at the hospital, we send this questionnaire after their visit, after the intervention, at all the patients and families. But then also we allow them to have an open, comments if they want to provide ideas and feedback. So now also what we are doing is we are working on sentiment analysis and analyzing all these open, comments. So this is a way for us to identify certain pain points when we see some patterns. But then on top of that, also to evaluate patient experience, we are developing a specific ad hoc PREMs, patient-reported experience measures. So this is what we are doing.
Okay, interesting. Joan,
and sorry, and finally, always, there is always the need of more qualitative evaluation. So it means that after the NPS, after the PREMs, always you need, in our case, always, we identify very randomly some patients and families, and then we have an in-depth conversation to go a little bit deeper.
Thank you for that.
Maybe also related to that there is a question about whether you give feedback to the patients and after all the activities, or if there is any kind of feedback foreseen.
Yeah, there are, here again we combine in different ways. One is we have these regular councils. One is from young patients and the other is families. So the Families Council, we meet once per month during all the year. So that's a good way to provide feedback on the actions and on the improvements. And plus then what we do is, for example, with all the patients and families that they participate in specific projects, for example, the project that Jordi was sharing, every time that there is a delivery, we share with them, look, this is the results of your collaboration, of your participation. And then also, as Jordi was mentioned, for example, when there are these general gathering meetings, as you know, with associations, also it's a good way to provide feedback. And then also this year, what we started is we open a specific LinkedIn profile, patient experience from Sant Joan de Déu, in which also is a channel in which we share more openly, the results and insights from these collaborations.
Thank you. There is also, well, I will take the next two questions. One, which is about if you face any resistance to change from the hospitals and how they were in tune to have this innovative approach. And also a question about the funding, how is it funded, and if you have specific resources for this.
I mean, in our experience, it's not that we have like a resistance, but it's true that our model of institution changed a lot of years ago. So we went for a model of, we say that we were not a hospital that innovates. It permeates all the structure. So innovation as patient care are in the center of the care, or must be, and we try to be. And so we don't have a resistance. Regarding the fundings, it's true. I mean, we were able to do this project about UVI to GAA thanks to this grant, and it was not a small grant because it's a long way. But it's true that other initiatives can be done, and once we have the structure, and I think it's like a idea of the hospital, to have a vet to have this kind of unit they can help in a more modern way. And the example is what we did for the Joan, the day of patients with rare diseases, with rheumatic diseases. We asked for their help, and they came that morning and were working with us, and we organized in a month, and it was an amazing. And it's true that as much resources as better, but if you have a good team with a small amount of resources, you are able to do great things too. So it's always better to have money, but without, there's a lot of things that can be done too. That could be my message.
Yeah, and building on top of that, I would say this way at the end, when there was the sum up on the slides, in terms of leadership, the first point, it was this huge commitment from the leadership team. So that's very important in terms of resistance. So patient experience and this type of collaborations and mindset nowadays are happening at the hospital because our general manager is the first encouraging that and sharing that. So that's for me, that's the first thing, because that's the way to facilitate. Because then, of course, also, even if it's difficult, always there will be ways, resources, or ways of doing that.
Thank you. And also related to non-monetary resources, there is a question about the time, no? How do you find time and how all the professionals in the hospital are finding the time to do this? But
I must confess, I'm always supporting rights of workers and balance of private life or working life. And I'm very concerned about that. But it's true that some of these things sometimes are out of our regular scheduled time. No? Of this, when we met with patients and family on a Saturday, it's not a schedule, but we are happy to do that because we want to facilitate, and we are not organizing a meeting when we know people are working. But it's a kind of philosophy, and again, I believe it's the way you work with your patients and your team, and your vision of how you must be the care of these children with rare diseases. No, we must find the balance for sure. Again, as much resources as better, economical also. But you can do things also without resources, and also you can find sometimes to do that experience. And moreover, and I think it has been mentioned, but at the end, it improves the care. So it improves your satisfaction. It improves the satisfaction of the family. So it's an investment. So maybe it could be that to do this investment also has a point of egoism, because you will work better and we will be more happy working. So yeah, sometimes you must do this better.
Yeah. On top of that, I think, the first thing is that in our case, we try to be always facilitators. Our role is how we could facilitate this work. And this means also even sometimes, try to adapt. And of course, the most important priority is the work that they do. That's the most important. This is why we are here. But then always there are ways to try to take advantage of. For example, if you know that every week the professionals are meeting, so take advantage of this meeting they already have and try to have your meetings during their, these kind of things, I think are facilitating a lot. And then, as Jordi was saying, at the end, it's a kind of a win-win situation. If you see that I invest this time, but at the end, this helps me to do better my work and have an impact on families and patients. So this is really fantastic. This is why we are here.
Thank you. I think that, yes, it is a culture of work also that is facilitating this. And we have some questions also about how these practices are related to ERNs. So if you have the opportunity to share these good practices with the managers from HCPs that host ERNs units, and also if this approach should be integral to all ERNs units and perhaps where the focus should be. So a little bit about the synergies between these kind of programs in the HCPs and the
ERN. Joan, the question is really a bit tricky because ERNs are very much composed by patient representatives and clinicians, and the hospital managers are not there, let's say, directly involved. But there is an opportunity, there would be a very nice opportunity to exchange on this hospital management good practices. And I was wondering if you've ever explored that. I know it's not easy, but yeah, that's the question. How could, you know, because I know, I mean, we get some coordinating teams asking us for questionnaires on patient experience with care that hospitals could use, because the part of the ERN evaluation, of the healthcare provider evaluation, that is part of the evaluation framework of ERNs, include that kind of aspects. And sometimes I wonder if more could be done in that area. And let's be clear here that it's not the focal point of ERNs to exchange on hospital management, but yeah, I was wondering if you've explored that at any meetings or any, I don't know, if there has been any activity there.
Well, I think, yeah, that could be really an interesting opportunity. As much as I know, at least since I'm working here at the hospital, I don't know there've been initiatives on.
No, but I mean, if I can say, yeah. I believe that it's a crucial point, and I agree, Ines. How can it be done through the ERNs? And if you understand how the ERNs were built and how are they organized with a strong patient involvement, or it must be. I mean, I believe that patients association also must take the lead and ask for that inside of each one of the ERNs, so they can just raise this question in front of the health providers. No, I believe this is together we can also ask for it, because it's not just about disseminating knowledge about patient journeys, about information about diseases or discussing clinical cases, but if we want to change things, maybe this is the way to advocate for good practices and how we can raise this to the healthcare providers. I don't know if this is your questions, but for sure, if all the ERNs raise this need, it could go higher in the decision table.
Thank you. Yes, I think that answered the question from Ines. So we have another question from Natalie about the potential to replicate and scale for other diseases and hospitals these kind of projects, because if a project takes 3 years, maybe it is hard to replicate in other environments. So how do you think that this can be improved with compromising quality of insights? I don't know, Natalie, if you want to give more information about. You are on mute, sorry. I cannot hear you.
Sorry, thank you for bringing that question up. No, you nailed it. It's perfectly the question. How do we scale it and make it more agile? Yeah, that's the question.
Well, you know, in this case, this was a research project with this, you know, this collaborative, and it's a 3 years project. But some of the projects that we've been sharing on the presentation also are projects that they last, you know, 6 months, 9 months, 3 months, depending on the scope of the project. So it doesn't mean that the project should take 3 years. In this case, I would say it's because it's you know, it's based on research, and that's important, no? But in other cases, you can do shorter projects, and I think a way to scale, well, first of all, you need to create awareness. If there is no awareness, there will be no possibility to scale. Then second, you have to show some results, and probably the best way will be to try to do some small pilot, you know, a short project in which you identify some of the healthcare professionals that they are interested on this type of approaches, and then develop a small pilot, and then to share this pilot on the meetings with all the other healthcare professionals, and from there, you will start something, no? And then in terms of resources, at the end, it's to show the value, because if you see that it provides you insights to be more efficient, to provide better care and higher satisfaction, then always there will be the resources to decide to this type of projects. And of course, a good way could be also in terms of the thinking more about all this network, to share a kind of tools or best practices or examples of that others they could learn, and of course then also to organize more events like the one today, or even a conference about all this, but with a special focus in this type of approaches. This for me could be good ways to make it scalable. That.
Thank you. I have maybe a last question also. I wanted to know more also about how you determine the engagement techniques. Do you have like a framework, a guide, or according to the age of the patients? How do you know which are the most appropriate techniques?
Yeah, we always try. We always try and learn, and we fail and we change. So, but basically, first, we keep in mind the difference in age, because the approach is completely different. So based on that, then based on the scope that we have on the project, then we try to see what are the best techniques. And always, normally, what we do is before applying, we always do a kind of a first pilot, in which maybe with 2-3 patients or families, we try the tools, and we see, okay, this is working, not working. Okay, once it's working, okay, now let's use and during the whole project, and then of course we have our own toolkit that we've been built during all these years, and it's the one that we use. And especially sometimes after, what we do a lot, it's because we are so lucky, we are in a hospital, so we can also discuss with our colleagues from psychology, mental health, so because they know a lot about cognitive stages, and so also with them a lot we discuss which are more appropriate.
Thank you. I think we are arriving at the end of this webinar, because we could stay here forever asking you more questions and questions, but unfortunately we are arriving at the end. So we'll have more patient partnership webinars in the upcoming months, so maybe we'll see each other again. I wanted, to thank you for this presentation, Joan and Jordi. That was very interesting, and I think that we have all learned a lot. And especially we have seen that it's possible not to have this patient partnership approach also in the healthcare services to improve the services. So thank you for this and for sharing this example with us. We will share also the recording and the slides in our website, so they will be available for all of you. Thank you again.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Bye. Thank you.